Okay, so as we've talked about already, there's often a lot of lasting effects that survivors of pediatric cancer have. So one thing that can be done about this is big data. A lot of different organizations and researchers are using big data now to follow some of the lasting effects, some of the determinants of cancer, and kind of track diagnostics and treatment that way. So we're going to hear from some of them today. So I guess first, Lillian, can you tell me a little bit about the day-to-day life of a pediatric cancer survivor? And I understand you have a personal story that you wanted to share too.
So I think that there's always the focus on cure. I mean, we have nothing if we don't have cure. But I think that what I hear from survivors is cure is not enough. And I think that the story from a patient really was a little bit shocking to me when I first read it. She shared this on a website, and she's okay with me sharing it with you all too. And she says that although her son is considered a survivor, the sad fact is that survival rate statistics that are widely shared with the public are so misleading. If a child survives 5 years and then passes away due to the chemical onslaught of drugs they were given to cure them, that child is still considered a survivor. Unfortunately, if the child survives but has permanent hearing loss, brain damage, loss of eyesight, disfigurement, liver disease, heart attack, etc., that is considered a win. Really, my mind and heart cannot accept that. We can do better. We must do better. So for survivors, although in pediatric cancer we have an 80% cure rate, 80% of survivors by age 45 will be living with a severe or disabling late effect. So I think that it's not just cure, it's cure with minimal toxicity, as Dr. Kripe talked about. I mean, we have to put that in the formula for protocols. So survivors come, and they come to late effects programs like we have, and they have roadmaps, if you will, to how they need to be followed so that if they're going to develop, if they're at risk for a late effect, we know how to check for it, how to diagnose it early, and to get them treatment.
So tell us about the Cancer Survivor Link. How did it come about? What was sort of the rationale for it?
So Cancer Survivor Link is a web-based, patient-centric communication tool. So it's something that was developed at Emory, and each patient or their parent registers, and in this website, it empowers them to take charge of their future health. Their medical summary, they're able to upload, and we always say there are 3 things you can do on Survivor Link. You can learn from the virtual libraries, you can learn about late effects, you can learn about what you need to receive to help you have good health and quality of life. You can store all your critical health documents because, you know, in this day and age, there's a lot of access to your medical records, but if you move from one system to another, they have different medical record systems. So now it's a huge problem to try to access the important documents. So you can upload them yourself, and most importantly, you can share. So, and when people are moving around, when they're transitioning from pediatric care to adult care, they can acquire new providers and give them access to their healthcare documents.
And how is it, can you kind of clarify why it's better than or different than a regular electronic medical record?
So when you have an electronic medical record, there are different servers or systems that, whether it's, I don't know, Cerner or Epic or whatever, that if you go to another hospital system that doesn't use that record system, you go back to getting your records transferred and uploaded and so forth. And you might travel or be on vacation. So
Right.
It's important to be able to always be able to get into your key health documents. If you have a health problem and need, while you're skiing, to go into the hospital, if you go in and you say, I'm short of breath, they're going to say, oh, it's probably asthma, it's probably pneumonia, you know, those are still big things. But if you look at them and say, I'm a cancer survivor, you'll see the physician's face go blank, like, oh, I'm not sure what that adds to the equation. Maybe it's a relapse. Maybe it's, you know, heart failure. Maybe it's something else. So now you have access to your documents, and you can print them and give them to them.
So that record would have everything, all the drugs you've ever taken,
Yes.
all your whole history of your treatments,
Yes.
relapses, everything.
Yes.
Okay, so you could just hand it over to the primary care Minute Clinic person.
Yes,
Okay.
exactly. And I think it's patient-centric. You're not dependent on a provider to do that for you.
Okay, so and kind of on the other kind of a component of that is the COVIKA program that you guys have built. Talk about how that got started. What was the need for that, and how did you go about putting it together?
Sure. So Seven Bridges, since 2009, has been working to develop ecosystems that help researchers analyze and share biomedical data to ultimately improve health outcomes. And the reason that we drive this work has been that we consider that genomics and medical data is really putting those together gives us the power to predict. So it gives us the power to predict what the long-term outcomes are going to be for someone. It gives us the power to predict who is most at risk for developing a particular disorder. And what we know is that the way that we increase that power is by bringing lots of data together. And it's really only by initiatives like COVIKA that we're able to bring researchers with different sets of data, allow that data to talk to one another, and then importantly, get that into the hands of researchers to be able to use that to drive discovery.
So yours is more of a personal electronic medical record, and yours combines data from lots of different patients to see what are the things we can learn from all of these different patient stories.
Yeah, and I think there's an interesting tension between the two of them, right? As was mentioned, each patient, there's a deluge of data that they encounter when they first get diagnosed, right? And then their whole records themselves is a huge amount of information that they essentially have authority over and in charge over. But at the same time, one of the biggest challenges we face in the pediatric space that's different than the adult community is that these drugs, like chemotherapy and radiation, do have long-term side effects. And these are children who are still developing, still growing, right? It's not as if any one of us would experience the same types of toxicities. And so there's a higher mandate for a precision medicine approach, for understanding the biology and targeting it. But the only way to do that in the context of a rare disease is to position that individual patients against a map of the world's largest data enterprise and figure out how does this patient compare to or is different than anybody else. And that's very challenging in a rare disease community. No single hospital has enough information themselves, right? CHOP is a phenomenal hospital with many, many patients, but we on our own could not essentially accomplish this. Similarly, we on our own don't have all the technologies and opportunities to really harness on behalf of patients. And so this is where partnerships between patients themselves and foundations, who are probably some of the staunchest advocates of empowering data on behalf of research, commercial enterprises like Seven Bridges, and scientists and researchers can come together on behalf of a community that is the most advocate you would ever find to drive an accelerated platform for discovery on behalf of patients.
So give us an example. So it's sort of almost like I'm a cancer survivor. What are my chances of infertility, for example? And then the doctor could cross-reference it against that? Or?
So one of it is prognostic, right? So there's an element of, in all fields of science, right, we essentially try to reduce the complexity and put a patient in this bucket or in this bucket or in this bucket. But each one of us is an individual who's very unique, even independent of disease. How do you interpret that uniqueness of a patient and the uniqueness of their tumor and make sense of it? And that's a very challenging space, right? We have 3 billion letters that comprise our genomic code. It's a highly complex environment that requires a tremendous amount of compute and analysis that allows us to interpret it. And once we can interpret it, we can have some prognostic and say, okay, you fall into this bin of patients that potentially respond to this type of drug. But at the same time, it provides opportunities for us to break barriers around silos. So particularly in pediatrics, this is a tremendous opportunity that now I think is being capitalized on. And that is that diseases in the pediatric space have a very different cause than in the adult space. Kids don't get cancer because they smoke or they're out in the sun, or they get it because it's a process of development often. And there are opportunities to intersect across diseases even. But there's so much information that I, as a neuroscientist, may not know about bone disease or cardiac failures in children, but biology is conservative. And the only way to connect is through data. And we have to do that much, much more rapidly than the human being can do it. And that's the way enterprises like COVIKA can support it. COVIKA essentially is a cloud-based architecture that centralizes and brings together data from researchers, patients themselves have uploaded data, the NIH, and almost any enterprise that can contribute into this context.
So I guess this is sort of a question for anyone, but a lot of what you're talking about, I mean, it's wonderful, but it almost seems to me like, you know, we've had iPhones for 10 years now. You know, we've had amazing computers for much longer than that. Why are some of these big data projects just coming out now? What have been some of the hurdles that you've had to get over in order to get to this point?
Right, everybody's looking at me. You know, there were some questions earlier on today, you know, around the political human space and how it intersects, right? And there's always this mix, right? Science is a human enterprise, right? And I completely agree. You ask any cancer advocate or patient or family, you know, in a time where, you know, the stock market does way more computing and analysis in a single millisecond than a scientist might do, right, across their lifetime. There's a disparity, right, or prioritization that we're only now are bringing to the purview of the healthcare space. Part of it, though, is a challenge to coordinate and centralize and connect. And that's something that, you know, the healthcare enterprise is only now sort of embracing. One way to think about it is that hospital systems are very much like grocery stores, right? You know, this is your hospital in your neighborhood, right? And hospitals are now reaching a limit to what they can do and provide and understand from that perspective. And the only way to empower that is through connectivity. Connectivity across patients, connectivity across researchers, and partnering with those who are leading innovation on behalf of technology. And so it's a unique moment in time that's really you know, coming to fruition, driven by foundations, parents, and those domain stakeholders who recognize that time is the most valuable thing you can essentially give a patient, right? All of these patients, Emily and others, it's a race against time. And time is something that data can actually impinge on.
Can I comment?
Yeah.
Because I think, too, that when we look at pediatric cancer, when we look back in the 50s, of course, our initial focus was on cure, and it's always been on cure. But then as we moved into the 90s, we were getting these very high cure rates, and then we were starting to back up and say, well, wait, how do these patients look now that they're cured? And remember, when you cure a child of cancer, you've got decades of life to go. And I think the same thing perhaps is happening in the use of big data. In terms of, I can't answer these questions about the best designed protocol based on the patients that I follow because I don't have enough. So especially in pediatric cancer, through Children's Oncology Group, we all work together to utilize data from everywhere to make those decisions. And I also see now that we're starting to do that even more so and utilizing the big cloud of tetrabytes or whatever you guys talk about. I'm like learning so much today, but we can then take it and fine-tune treatment to the late effects, you know, the top late effects that are going to impact health and quality of life. Let's fine-tune the treatment based on what will work and then what will minimize the key late effects.
Got it. I think we have time for some questions from you guys. Questions? No questions yet? Okay. No hands. Okay. So I was wondering what else, so we have these great databases. What else do survivors need to help with some of these late effects? Like what else are you guys working on to kind of try to bring it to the next level or to really harness this data in order to improve treatment?
So I think one thing that, and I think this maybe is an important distinction, right, is that, you know, a database is one version of thinking about, right, centralizing all the information. But the other space, and this is where COVIKA and I think, you know, even some of the other platforms really participate in, it's not just the data, it also brings people together in an environment where they can compute, analyze, find other people who know something. Maybe a plant biologist has some information that I, as a brain tumor scientist, do not. And so I think, we always talk to patients, and the phenomenal part is that, parents like Emily, and Carolyn, they're walking storage data people, right? I mean, if you talk to mothers and fathers of patients, they know their whole patient's history, what happened to the minutia. That's never centralized or connected. And however, they connect to each other and cross and compare and analyze in ways that they just sort of do ad hoc. So empowering them, right, and their store of data, right, in ways that they contribute, but also, is compared to and analyzed in the context of the molecular. These are the new opportunities that I think really de-silo how we do research across diseases and across, different domains of expertise from our perspective.
Anything to, sorry, you look like you.
I like that idea of connecting people that you wouldn't necessarily think would be playing a role in this, plant biologist, anything. I mean, I just think that trying to bring tetrabytes together and people together, people who want to think together creatively, innovatively about, and then empowering survivors. The biggest thing I can do as a clinician is educate my patients and teach them how to advocate for their health, because I think that that's a key component, and it's lifelong. It's not, when I always get the question, when am I done with cancer? Unfortunately, you're not done. You're never done, because some of the late effects can occur right at the end of cancer treatments, and some begin 5 years, 10 years, 20 years, 30 years after the completion of treatment. So not only to educate patients, but also other healthcare providers, I think is really key.
When you say advocate for their healthcare, what do you mean by, in what way would a doctor not just listen to a cancer survivor? Or what are the circumstances in which they would have to advocate for themselves?
Oh, I wish they didn't. Unfortunately, I can't tell you the number of times that a survivor has maybe had chest pain or palpitations, a rapid heart rate, and they would go into their primary care physician, and the response would be, "Oh, honey, quit worrying. You finished your cancer treatment 10 years ago." That's not the right response. I mean, there's congestive heart failure, there's valve abnormalities, there are all kinds of abnormalities that happen in the heart after it's been exposed to chemotherapy or radiation.
And that, I think, is an important point, right? In the context, people think of cancer as organ-specific, right? Mm-hmm. You have a brain tumor, you had a brain tumor. But Seven Bridges, ourselves, and many others are recognizing that the real opportunity is not just connecting across pediatric cancers, or even across pediatric and adult cancers, it's across all of data. And some of these initiatives are also now being partnered in the context of, even at the NIH, we're part of a new initiative called Kids First, that for the first time will bring pediatric cancers and birth defects into a common space. And that's because historically we know there's some overlap between someone who has a cardiac birth defect and someone who might get a cancer, but nobody's ever put the two spaces together before. Yeah. So these new initiatives where data connects, right, and people connect, and those two layers of connectivity come across each other, are going to transform the way we think about healthcare, so that the advocate space, right, is data-driven, right? Patients are data-driven themselves. They go home the minute they're diagnosed, and they go on Facebook, and even if they've only had high school biology, they'll come in the next day and ask us for whole genome sequences at this depth, and right, and I want this analysis, and I want so-and-so there to analyze it. That's because the community is a store of knowledge, and that's what we want to empower in ways that I think will be transformative in how we think about it.
Totally.
So one thing I think also that we'll see over the next several years in the data-driven focus and long-term survivorship is new ways of early detection and less kind of emotionally stressful ways. I think imaging procedures can be very stressful and expensive. I think we'll see liquid biopsies coming online and making an easier way for us to be able to do rapid monitoring detection. And that's going to be, to get there, we're going to have to, again, bring together a wide variety of data, both the genomic as well as the outcome data, to make sure that we can bring those connections.
Yeah, and so hopefully we won't be seeing some of these late effects soon in the near future.
I'd love to be out of a job.
Yeah, of course. Well, thank you so much, Lillian, Adam, and Brandi. I really appreciate you guys coming. Yeah, thank you.
Great.